20 years since the establishment of the leading cancer center in the Arab world. 20 years of the best medical minds gathered under one roof. 20 years celebrating strength, survival, and new beginnings. Bearing the name of Jordan's legendary leader, the King Hussain Cancer Center was established by King Abdullah II with a mission to provide the most advanced cancer care to every Jordanian and every Arab patient. Our internationally accredited center provides integrated space for patient care, education, and research. Our patient-centered approach to cancer care is enabled by a highly qualified medical team. In state-of-the-art facilities, which offer privacy and comfort, and an outdoor sanctuary to promote healing. Children at KHCC receive specialized attention in child-friendly spaces dedicated to treatment, recreation, and continuing education. KHCC's jewel in the crown, its bone marrow transplantation program, is one of the largest in the Middle East and is able to perform 300 procedures annually with success rates commensurate with international standards. Our center is equipped with the most advanced cancer care technology available, including a cutting-edge robotic surgery system, the first of its kind in Jordan, and an innovative brain lab which integrates the most sophisticated brain navigation system with advanced MRI technology. Our cell therapy and applied genomics lab delivers highly advanced personalized medicine through cellular therapeutic and genomics-based technologies. It is home to the only public umbilical cord stem cell bank in Jordan. KHCC is certified as a teaching hospital for hundreds of medical students at Jordanian universities, and our Education and Training Academy has made the KHCC a regional hub for superior oncology training through its academic offerings. KHCC recognizes research and innovation as the future of the fight against cancer at both the individual and institutional levels. To advance these efforts across the region, we launched the King Hussain Award for Cancer Research in 2020. Our efforts have no boundaries. The King Hussain Cancer Foundation supports the treatment of thousands of underprivileged patients, including refugees, through our Goodwill funds. Looking to the next 20 years and to ensure that no one will be deprived of treatment due to lack of capacity, KHCC is embarking on several groundbreaking expansion efforts. Satellite centers providing accessible care to patients across Jordan through the construction of a new center in Aqaba named in honor of His Majesty King Abdullah II, a standalone pediatric center in Amman, and a new ambulatory care center with integrated research laboratories. This is our story, a Jordanian institution that has grown into a world-class, life-saving cancer center. This is the legacy of King Hussain. This is the vision of King Abdullah II. This is the pride of Jordan.
Good afternoon, everyone. Thank you so much for coming. It's a real pleasure to have the King Hussain Cancer Center tell you the story that you just saw in this video in a few minutes. This took more than 20 years of actually very hard work to build this amazing cancer center. It's really a success story in a part of the world that has limited resources. And this center, as you will hear, provides essentially free care for almost all Jordanians and many refugees who come from the area to get care in Jordan. So it's really a true pleasure today to have Her Royal Highness Princess Ghida Talal, who's the chairperson of the King Hussain Cancer Center Foundation, who's going to tell us about the story of how the Cancer Center started at the beginning and how it grew over time. But also Dr. Asem Mansour and Dr. Hikmat Abdel-Razeq will tell us about the medical aspects and the research aspects of the Cancer Center story. So Her Royal Highness Princess Ghida has a very long history in helping philanthropic efforts across the region, really, to get support for the Cancer Center. She actually has had a degree or has a degree in journalism in the grad and undergrad from Georgetown. So she's an outstanding speaker, as you will hear very shortly. And she has also led the establishment of the King Hussain Cancer Award that you just heard about, which is, I think, probably the first big program in the Arab world for cancer research promotion, as well as enhancing the ability of the Cancer Center to deliver care across the region. So it's really a true pleasure to have you, and thank you so much for accepting our invitation.
Good evening, everybody, or good afternoon. Thank you, Dr. Amir. I just have to correct you on one thing, is that I graduated from the School of Foreign Service, not journalism, but I did work as a journalist later on. I'm really here to tell you about our part of the world, about the story of a cancer center in our part of the world, in the developing world, and how we fight cancer in the Middle East, how we fight cancer even though we are resource challenged, and we do a good job at it. So I first want to thank you, Dr. Zaidan, for your warm and generous welcome, and for inviting me to join you for your grand rounds. I know that the grand rounds at Yale are very prestigious, and I'm very happy to be one of the speakers. So I'm also delighted to be here at Yale, of course, this formidable institution that has shaped some of the greatest minds and produced 50 Nobel laureates. It's quite impressive. And I feel privileged to be with the dedicated leadership of the Yale Cancer Center and the medical healthcare professionals to basically observe and attest to your life-saving work that has had an immense impact on the fight against cancer. Today, I bring a story of success from my part of the world, from the Arab world, from Jordan. 22 years ago, I was tasked by King Abdullah II to establish the King Hussain Cancer Center and Foundation, KHCC, at a time when prospects for cancer patients in our region were extremely bleak. There were no options for cancer treatment, and adequate treatment was basically non-existent. But as I speak to you today, KHCC has transformed the landscape of cancer care in the Middle East region by providing the most advanced treatment, by leading regional research, and by extending its care to Jordan's refugee population at no cost. I'm certain that many of you know that Jordan has received the largest number of refugees with Turkey. About 1.5 million refugees are in Jordan. At KHCC, we also had to work hard to dispel the stigma that is associated with cancer. Basically, that the disease is an automatic death sentence. And when we began our mission, women's health topped our priorities, as breast cancer has long been a significant threat. So by conducting extensive early detection awareness campaigns, we succeeded in actually flipping the statistics, reducing by half the percentage of women who get diagnosed at the late stages of their disease from 70% to 35%. But we will not rest until we get to the number 0, when no woman has to die simply for not getting to treatment on time. Over the last 10 years, we have spearheaded cancer research in the Arab world as the only hope for a cancer-free future. So in 2020, we launched an international research initiative, the King Hussain Award for Cancer Research, with the aim of empowering and recognizing the efforts of individuals and institutions pushing the boundaries of cancer research in the Arab world. And I'm proud that today, 40 women at KHCC are directly involved in scientific research. And it's also worth noting that nearly half of our center and 47% of our positions are women. Throughout our journey, we developed strong and critical partnerships with international leaders in cancer care, chief amongst them, St. Jude Children's Research Hospital, MD Anderson Cancer Center, and many others across the globe. Today, the King Hussain Cancer Patient treats about 6,000 new patients annually and receives 350,000 outpatient visits per year. We have so far treated in 21 years over 70,000 patients, 70,000 patients who may have had nowhere to go had the King Hussain Cancer Center not been established. Among those are thousands of underprivileged patients from across the Arab world, from Palestine, from Iraq, from Syria, from Yemen, from Sudan, from Libya. Many of them are, of course, refugees and displaced people who have fled to Jordan to escape violence, turmoil, and disintegrating healthcare systems in their countries. The treatment of these refugees is made possible by KHCC's Goodwill Funds, which support our most generous patients, most vulnerable patients who would otherwise remain untreated. To date, KHCC has funded the treatment of nearly 5,000 underprivileged patients at a cost of 150 million. But we cannot shoulder the burden alone. The support of the international community has been insufficient in the face of the devastating tragedies that have hit our region. This is the reason I consistently call on all parties and donors to support our unrelenting efforts to treat displaced people facing cancer. Dr. Zaidan, we are so proud that a son of Jordan achieved excellence in his field, and especially at an institution as esteemed as Yale. We are grateful for your unwavering support of the King Hussain Cancer Center, and we look forward to continued mutual engagement between our two institutions. On behalf of my Jordanian colleagues, I would like to thank again the leadership of the Yale Cancer Center for their invitation and for the warm welcome. We look forward to welcoming you all to Jordan, to our beautiful country, to witness firsthand the life-saving work that takes place at the King Hussain Cancer Center on a daily basis. Thank you.
Thank you so much, Your Highness, for those introductory remarks. So now we are going to the main part of the presentation about the story of the King Hussein Cancer Center, really as I think as a very good example of how excellent cancer centers can be built in countries with limited resources, especially with cancer becoming a very global problem. I had luck of having witnessed the progress of the cancer center in Jordan, because I actually did a year before I came to the US in 2003, and I have seen the new heights that the cancer center keeps reaching to. So it's really a pleasure to have Dr. Asem Mansour, who's the CEO and the Director General of the Cancer Center, who will talk to us about the story of the Cancer Center. He's a renowned radiation oncologist, but importantly, he's actually a very creative writer. This is a book that he wrote during the Corona period, which actually was excellent in terms of showing all the emotions that went through this period. And I wanted to quote one quick paragraph from the preface of the book, where he says that the duty of the cancer physician is not simply to prevent death or to try to roll the clock of time backwards, but to embrace the patient and to help them find a new meaning to their life and to navigate the most difficult periods of their lives. So I think this really fully embodies what cancer care is truly about. And also we are privileged to have Dr. Hikmat Abdel-Razeq, who's the Chief Medical Officer and the Deputy Director, who's also a very renowned global researcher in, especially in breast cancer. And both of them have done tremendously for the last 20 years to build the cancer center. Thank you so much for coming.
Thank you, Amr. And good afternoon, and thank you for giving us the opportunity to share our story of a cancer center working in a country with limited resources. And as we all know, cancer burden is increasing worldwide. And given that its management paradigm is associated with a tremendous financial, social, and physical challenges, the developing countries are barely able to cope up with the increase, exponential actually increase in cancer services. And the situation with our countries, with limited resources, is even worse. Not only if we have a factor about the differences between cancer care in countries with limited resources and more privileged countries, it's not only in the financial and economic factors, but also the geopolitical arena of the low and middle income countries is also different. This is why cancer care in countries with limited resources is also different. Jordan, like many other countries with limited resources, low and middle income countries, is undergoing multiple transitions all at once. And for all of these, there are regional and countries specificities. There are also transitions in the epidemiological and demographic arenas. This is why cancer care in Jordan is different. And despite that, we have witnessed transition from communicable diseases, from infectious diseases to NCDs, but still infection is contributing to morbidity and mortality in countries with limited resources. This makes us facing double hits of two groups of diseases at the same time. Jordan is a small Arab country located in the Eastern Mediterranean region with a total land area of approximately 90,000 square kilometers and a population of 10 million inhabitants and population annual growth rate of 2.5%. And despite the country is facing challenges in terms of lack of natural resources, scarcity of water, of oil, high unemployment rate, high rate of inflation, but still Jordan is enjoying an excellent healthcare, and it's considered a hub for a treatment for different diseases, including cancer, for the whole region. About cancer, the Jordan Cancer Registry, the National Cancer Registry, was established in 1996, and since then the number of new cases, cancer cases, has doubled, reaching 7,000 or more than 7,000 cases among Jordanians. There are also 2,500 other cases among non-Jordanians. These are either refugees or patients coming from other countries to Jordan for treatment. And for a country which with high prevalence of smoking, it's not surprisingly that lung cancer is the most common cancer, followed by colorectal, bladder, prostate, leukemia in male, and in females, as expected, breast cancer is the most common cancer, followed by colorectal, thyroid, and uterine cancer. And you have to notice here that cancer like bladder cancer, leukemia, and non-Hodgkin lymphoma are among top 5 cancer in Jordan compared to the global data, where none of them is existent in the top even 10. The other thing, virus associated or cancers associated with viruses or caused by viruses are not highly prevalent in Jordan. If we take cervical cancer, for example, we diagnose only 40 cases per year. This is due to low prevalence of HPV. The same applies to liver cancer, the hepatocellular carcinoma. We diagnose only 70 cases per year, which is less than 1% of all Jordanian cancers. This is not the case for all countries in the region. If we take Egypt, for example, Egypt is not far away from Jordan, but liver cancer, hepatocellular carcinoma, is #1 cancer in Egypt due to high prevalence of hepatitis C, iatrogenic hepatitis C. The Jordanian population is young, but this is changing rapidly. We are moving now, like most of the countries in the region, from the expansive pattern of a population pyramid to a constructive one. 80% of Jordanians now below the age of 45, and only 3.5% are above the age of 65. And as we all know, age is the most common risk factor for developing cancer. For pediatric malignancies, as expected, leukemia is the most common cancer, followed by brain and CNS, lymphoma, and bone. For death-associated cancer, lung cancer is contributing to the highest percentage of death, followed by colon cancer and breast cancer, and this is the case for most of our countries. When we speak about challenges we face while providing cancer care, we can group those challenges into 5 groups. Challenges related to the medical services and infrastructure, to human resources, quality management, public awareness, and financial burden. When we talk about the infrastructure, lack of connectivity and fragmentation of care is a problem in Jordan, where patients' information is not moving between different providers, and it's not uncommon for a Jordanian cancer patient to get diagnosed in one place, staged in another, and treated in third or even fourth. Centralization of services in big cities is a problem, despite Jordan is a small country, but with high level of poverty and poor public transportation, this might contribute to delayed in cancer diagnosis and treatment. Lack of proper referral system is also a problem, where Jordanian patient, when he or she diagnosed with cancer, they don't know from where to start and where to go. Human resources is a global problem, but has some specificity in a country well known for excellent human resources in healthcare and others. But we are situated in a sea of high-income countries, oil-rich Gulf countries, which attract our people to go there seeking a better income. Dr. Hikmat, in the second part of the presentation, will address this issue and how we overcame this problem. Sustainability and consistency in a geopolitical uncertainty is a problem. And the quality of care in Jordan and other similar countries is not equal among all providers. Also, the primary health care is weak. This is why we had to jump in and to fill this gap as a cancer center. And this imposed a tremendous pressure on us to fill the gap in awareness, early detection, and long-term follow-up after treatment. Although many of our countries are having a national cancer registry, but those cancer registry are lacking outcome data, and they are lacking a proper quality assurance mechanisms to ensure the quality and accuracy of data. This is why we established at our center our own hospital-based cancer registry. We collect data, detailed data about each and every patient, and we publish this data. This is for our 5-year survival for breast cancer, for example, for colorectal cancer, for lung cancer, and this is our acute lymphoblastic leukemia, pediatric ones, in comparison to the SEERS available data. And as you notice, both curves are superimposed, indicating very comparable outcome. Public awareness is a problem in a country where tobacco is a public health emergency as per WHO. Jordan is among top 3 countries in the world in the prevalence of smoking. 60% of Jordanian males are smokers, 1 out of 6 boys are smokers, and 1 out of 14 girls Jordanian are also smokers. And 80% of Jordanians are exposed to secondhand smoking. Again, has been diagnosed at a later stage. We have witnessed some improvement in that, as Her Royal Highness mentioned, in breast cancer, but still this is way far away from we wish to see our patient with cancer diagnosed this stage. If we go to the National Cancer Registry, it will not help us because, as you notice, most of the diseases are not staged or not reported. Again, we went back to our own cancer registry, hospital-based cancer registry. Again, cancer is diagnosed at late stage. This is for colorectal cancer, for example. More than 75% are diagnosed at stage 3 and 4. For lung cancer, it's even worse, where 70% of our lung cancer patients are diagnosed at stage 4 with metastasis already. Jordan and other countries from the region have moved into westernized lifestyle. This is why there's high prevalence of obesity, where almost 68% of Jordanians and many countries in the region have body mass index above 30. The same with the physical activity or inactivity. There is also lack of integration of supportive services. Actually, it's not available in most of the institutions. KHCC is the only institution in Jordan with the comprehensive palliative and home care, with the comprehensive psychosocial and spiritual services and survivorship post-cancer living support system. And finally, the financial burden, financial toxicity is a problem everywhere. Jordan spent 8% of its GDP on health, but still we spend mainly on treatment, not on prevention or early detection, and this is the problem. The second problem that most of what we spend is been spent on people with NCDs with chronic diseases. Again, financial burden has aggravated by several factors, including late stage diagnosis, younger population, then we have longer follow-up, over-treatment in the absence of clinical practice guidelines and protocols. There is tremendous waste along the supply chain, and refugees, as Her Royal Highness mentioned, is a problem. This is why we formed our Goodwill Funds, as Her Royal Highness mentioned, and we spent before COVID $135 million. Now, Her Royal Highness updated this number that we spend $150 million on refugees and underprivileged. Jordan is a home for the largest refugee population, 1.5 million of them Syrians and 1.5 million from other nationality over time, and this trend, unfortunately, will continue to rise. Dr. Hikmat and his group published the disparity in cancer care and access to cancer care among Syrian population, breast cancer Syrian refugees, and only 35% of those qualified to have breast reconstruction had the breast reconstruction. For radiation oncology is a bit better because this is outpatient service, but still 77%. But for targeted therapy, only 1/3 of women eligible for anti-HER2 therapy or CDK4, CDK6 inhibitors get this treatment, and genetic counseling, or 12% have genetic counseling. This has translated into another study published by the same group comparing overall and disease-specific survival for breast cancer between Jordanians and refugees, and due to late diagnosis and poor access to care, there is much more or better survival among Jordanians comparing to the non-Jordanians. Our story as KHCC, as Her Royal Highness mentioned, the center was established in 1991 as a comprehensive cancer center. We signed an agreement with the National Cancer Institute of the USA, and then we started our journey to transform our center into a world-class center. We realized early that we should have strong governance, and our governance is the Board of Trustees chaired by Her Royal Highness Princess Ghida Talal, under which we have the foundation, which is responsible for fundraising to help us fulfilling our mission, and the center, which is the medical arm. Both the center and the foundation are working on awareness and advocacy. The center has major expansion in 2017. Now we have 350 beds with state-of-the-art ORs, linear accelerators. We have 6 linear accelerators. Now we are expanding to have two more. One of them is MR-Linac. We have state-of-the-art diagnostic and treatment tools to help us fulfilling our mission to provide people of Jordan and the region with the best available cancer care. We also incorporated supportive service. Before the era of KHCC, these supportive care, services did not exist. We have the psychosocial, pain management, physical therapy, nutritional services, patient support groups. Those concepts were first introduced by King Hussain. This has translated in huge number of patients. We treat, as Her Royal Highness mentioned, 6,000 new cases. 75% are Jordanian and 25 from all over the Arab world. Accreditation and the quality of care was very important to us. We were the first institution to get Joint Commission accreditation in 2006. A year later, we were the first center outside the US to get a disease-specific accreditation as a cancer center. We are proud that in 2019, we get the Magnet Award for Excellence in Nursing Care. In the same year, our Human Protection Program got the AHARB accreditation. The importance of international collaboration was mentioned by Her Royal Highness. This is very important. This is why we built a strong network of collaborations on the international, regional, and national levels. Cancer control in a country with many high risk to develop NCDs is very important. Our Cancer Control Office is involved in understanding and managing risk factors, and mainly we are dealing with tobacco as a priority. We brought to the Jordanian literature for the first time an atlas of the status of tobacco in Jordan and the Arab world. Early detection, we started with breast cancer, as Her Royal Highness mentioned. Now we embarked on a research project on lung screening for lung and colorectal cancer in high-risk population. And we anticipate that by the end of this year, we will have a result about the feasibility of performing these interventions. Clinical services, we have a horizontal organizational structure around services, multidisciplinary services, covering all disease side, and we mandate that we have unified treatment approach and in-house pathology and radiology review for all cases, and we mandate that each service has process and outcome indicators. Also, we established niche programs. A representation of it is our bone marrow transplant, which is the largest and most advanced in the region, was established in 2003 with the simple procedures, and nowadays we perform each procedure, bone marrow transplant procedure, and actually now in the plan, we are in the planning phase to establish our CAR-T-cell in collaboration with Mayo Clinic and St. Jude for pediatric patients. This is some of our data on bone marrow transplant. We treat all ranges of age ranges. We treat pediatrics and adult. We do allogenic and autologous transplant, and we do transplant for benign and malignant diseases. Expansion, Her Royal Highness mentioned about the Aqaba branch, actually in the video that you watched, but most importantly, that we built a partnership with the Ministry of Health to operate a cancer facility in the largest public hospital in Jordan in the poorest part of Amman. And the aim was to allow Jordanians, regardless of their socioeconomic class, to have access to the same equality of cancer care. In the first year of this collaboration, we treated 800 new cancer patients according to our protocols and by our people. This is our Aqaba branch, and this is our future. This is our pediatric cancer research hospital. On this, I will stop and I will give the floor to my colleague, Dr. Hikmat, to give the second part of the presentation. Please, Hikmat.
Thank you, Asem. My talk will be a focus on research and education and training. And the history of research really dates back to 2010, when we kind of believe that we are really reaching up to clinical, so it's a time to go to research. And obviously, we have lots of the thoughts in research, but we all believe that research is a must, even in low-income countries. And this is because we need to understand the disease trend and the risk factors in our particularly populations. So for example, in 2020, there was close to 20 million new cancer cases diagnosed. The anticipation is that the 30 million cases will be diagnosed in 2040. And bulk of those cases is going to be from the low-income countries. If you look at the slide, you see that the 50% or more of the cancer burden in 2040 will be from Asia, for example. Things will be much worse, actually, if you watch this slide. And poor countries like the African ones, the percentage of increment of the breast cancer, for example, is going to go from 203,000 cases to 450, which is an increment of 125%. And that's compared to only 65% increment in North America, for example. And we also believe research is a must because we have to come up with invention and innovation in cancer care delivery and outcome in order to reduce the cancer-specific mortality. If you look at the data and anticipated data from North America, cancer deaths would increase by 45% in 2040. But if you look at the African countries, that percentage is going to be exactly double. So the amount of the cancer deaths will be reaching an epidemic in countries like ours. And that also would improve the quality of the care for those cancer patients and should also inform in the cost of cancer delivery. This is the US alone. It's anticipated that in 2030, close to $250 billion will be spent on cancer care alone. And this is the slide a bit old from 2020 before the introduction of lots of immunotherapy and CAR T cells. So the anticipation is that much more than this numbers will be spent on cancer care in Western countries. And this is just because of the cost of the drugs. This is just an example. It's not unusual to pay close to $100,000 for one cycle of chemo or immunotherapy nowadays. So it's been a routine. And this slide would show you that the 20% of America, for example, would pay out of pocket the co-payment of $20,000 or more. This is in westernized countries, just to illustrate to you that how much of a cancer cost would be a problem in low-income countries like ours. Yet the bulk of research related to cancer is done in the Western countries. The slide showed you that only 8% of the clinical trials are conducted in low-income countries compared to a bit more than 90% in westernized ones. And not only the quantity of research, but also the priorities. In yellow, this is the European priorities. You see bulk of the research is being done on non-NCDs, on cancer and chronic illnesses. While in African countries, in blue, you see bulk of those researches are done in infectious diseases. So it's really both things, A, the quantity, and B, the quality and the priority of research is really totally different. So these are the lots of challenges really that we feel that we have to generate the country-specific evidence. We have to have our own data to better have effective preventive programs, early detections, better access, and improve our survivorship and palliative care programs. And when it comes to generating the cancer-specific data, I feel the cancer genetics is the biggest example, as illustrated by Her Royal Highness and Dr. Asem. This is really when we started, we think that the cancer genetics in our part of the world is a bit different. This is a collaborative research with MD Anderson that when we prove the concept that cancer genetics, the BRCA, is a lot higher in our country compared to what's being published. And this is when we started testing each and every eligible cancer patient. We have data now in over 6,000 patients tested for germline mutation and to see the patterns. And this is where data was presented at San Antonio at ASCO and was published just 2 months ago, illustrating that 14% of eligible Judean patients are having germline mutation in one of those genes. And specifically, 50% are BRCA1, BRCA2, but the other 50 in genes other than BRCA1 and BRCA2, like it's being published in the Western literatures. So these are some of the challenges that we face with research. There's country-specific challenges, the institutional one, investigator and patient-related. When it comes to country-specific challenges, we live in lots of regional conflict and instabilities. Countries in blue, where we do have the active political instabilities. Now, when it comes to also countries' challenges, we have issues related to policies, procedure, regulatory framework related to genetic research, tissue banking, material transfer, and cancer registry. And when it comes to cancer registry, it's extremely important to have the kind of data to better assess the cancer burden, better do epidemiological studies, planning, and evaluation of healthcare. And it is the only source for rich areas where you can judge the feasibility of what's ongoing clinical trials. Unfortunately, in Yale, you see here, only 24% of low-income countries do have the cancer registries compared to close to 90% in westernized one. This is our journey at KHCC establishing the cancer registry, which was started in 2006, who was the first in the region. Back then, we used CDC softwares, but nowadays we use the commercial ones. We have data of over 65,000 cancer patients, and that's probably helping us deciding in feasibility of research. And nowadays we do have cancer registrars, and those are improving a lot in the quality of the data kept. We do have also institutional challenges when it comes to research infrastructure, trained human resources, and lots of those who are trained enough would leave the country and difficult to recruit back. We have also issues related to grant money, access for a grant, access for new drugs, and obviously we have challenges related to visibility at a global level. At investigator levels, we have issues because lots of us were not trained to be investigators in medical schools. And we have also heavy clinical duties at the hospital. So to balance the clinical care versus research is always an issue. Research protected time is not existing in our part of the world. We just started that at KHCC. Also, incentives would accelerated career progression be an enough incentive for a researcher, or it should be top that in salary and financial incentive too. Medical writing is an issue also in countries where English is not the native language. When it comes to patient, I intentionally kept the slide empty because we have not really felt that patient is different. So we have no challenges when we approach patient to be recruited into clinical trials. So patient are the best example where all of them would love to go into a clinical trial to get access for new drugs. And we feel that to enhance research, we need to network with collaborators to promote knowledge, sharing experience, easy access to funding, great visibility, and opportunity to get access to drugs and technologies. And one of the best examples that, in addition to what was mentioned about MD Anderson, St. Jude, we geared up with ARTC. This is the European Organization for Research and Treatment. We currently host the regional liaison office for the whole Middle East regions. We participate in breast, lung, GI, quality of care, and almost all ERTC groups. And this led us to increase our publication. If you zoom in, as you see here, we published last year close to 200 papers with reviews, case report, etc. And these are the cumulatively aggregated number of clinical trials, close to 80 now running at KHCC. And this is the King Hussain Award for Cancer Research, Princess Ghida mentioned. And these are the 2 years already, 2021 and 2022. And this, the third one will be upcoming this November. There's an award for academic program excellence and another one for lifetime achievement, a third one for promising researcher grant, and a younger investigator, the fourth award. Now, it comes to training and education, a few words. In order to keep the staff at KHCC, as mentioned, we have close to 500 physicians, over 1,000 in nursing, 150 pharmacists, many of them are clinical pharmacists, and we have 1,600 of the others. But we face the brain drain. Lots of those trained physicians would leave the country and difficult to recruit back. And this is why we built the strong academic affairs and academic peer programs. This is the GME office, the Graduate Medical Education Office, We have the undergraduate medical education, residency program, and transitional fellowship programs. We have also a training academy for a structured and unstructured training program. We offer postgraduate education. We offer master degrees and diplomas. I will show you. And we are affiliated with the largest university in Jordan, University of Jordan. And this is our residency program. We have a 4-year residency programs in additional oncology, pathology, nuclear medicine, etc. We also have the transitional residency programs and the big 3 programs, internal medicine, general surgery, and pediatrics, but also the strength in the fellowship programs. We have programs in medical oncology, surgical oncology, pediatric oncology, etc. Not even that, but also we have the KPIs. We participate in the US in training exam. This is for medical oncology, for example, where over 200 programs in North America participate with over 2,000 trainees. All fellows in the States need to sit for the exams. We started doing so the last 10 years. And over the last 10 years, we always rank among the best 3 institutions across North America. So this is really just to illustrate to you that the quality of the trainees that we have match those in Western countries. However, this is really a record of one of our trainees. As illustrated, she did perform in every aspect in clinical and medical oncology, but you see in yellow, she significantly underperformed research, which illustrates to you that research is not being addressed at medical schools in our part of the world. This is where we need to do lots of work in there. We offer master degree in cancer informatics in collaboration with Bristol and University of Jordan. We also offer diplomas in palliative care, respiratory therapy, and pain management. We also have a strong training program in pharmacy, a strong internship program, pharmacy residency, pharmacoeconomics and pharmacogenomics, clinical training programs, and also research training for pharmacists. Nursing is not really forgotten. We have really also strong training program for nursing. This is an oncology nursing residency program, which is accredited by the American Nursing Credentialing Center. And to manage our brain drain, this is a paper we published 3 years back at GCO, Global Oncology. We feel the strongest way to do it is to have a strong local training program, accredited one, with international collaboration, with leaving some flexibility for our guys to move around. And this is the experience that we had with Prince Margaret Hospital, where lots of our trainees spend a year or 2 over there, get trained in specifically areas. In conclusion, cancer burden in low-income countries is an ongoing and increasing problem. Patients still present with advanced stage disease, and this is why we have to have a strong prevention and early detection programs in order to inform in the cure rate and the cost of treatment. Country-specific data and evidence are highly needed because we feel we are different from what's been published in the West, and the only way to do that is through research. We have to manage brain drain through a good training and education, the offices and centers, and the center of excellence in low-income country is doable, and we've just showed you our own experience. And international collaboration with institutions like yours is a must in order to get what we already have achieved. With this, I stop, and thank you so much.
Thank you so much. Excellent presentations. And I know we have also a lot of audience on Zoom. So I encourage you, the goal of this visit actually is hopefully to establish ongoing collaboration. So whether you work on population science, translational research, clinical research, any kind of avenue of collaboration you think of, please email me, and I'm going to be happy to connect you with the right people at KHCC, and hopefully we can get some good collaborations going to help them move the field forward. So any questions for our speakers today? Yes, please. Let me just...
Traditional medicine. What is the role of traditional medicine today?
So yeah, Can you repeat the question just for the Zoom audience, please?
Yeah, so the question is about the being the Arabic medicine is the old one. What is the role of alternative medicine and traditional medicine in cancer care in countries like ours? Well, almost every other patient in Jordan and in our part of the world do take alternative medicine. We have already published some data about the use of alternative medicine. But however, very few believe in just taking alternative medicine, not going through chemo and immunotherapy. We face very few, occasionally a patient who would refuse getting chemo and radio, for example, and go for alternative medicine. But they go both hand in hand. But there is a significant portion of our patients who use alternative medicine, but in addition to chemo and other medications.
Yeah, Dr. Harbs.
Yeah, but obviously, like Her Royal Highness stated, she just mentioned an example just before we entered the auditorium here about a patient who refused to take the chemo, a patient with breast cancer. This is a totally curable kind of a cancer. And she would not agree to take chemo or immunotherapy until she had a very advanced stage disease where nothing would really work. But we still face some of those. But I have to declare that none of alternative medicine is as good as or even close to a chemo or immunotherapy nowadays.
I really enjoyed the presentation. Thank you all for coming. I noticed in some of your data, especially lung cancer, the late stages of diagnosis, especially at a time when our best therapies are moving to the earlier stage disease. So I'm wondering what efforts you're doing for screening in your country, and also, of course, the smoking rates being so high, what you're doing for smoking cessation.
Yeah, we rank probably number 1 or number 2 worldwide when it comes to smoking. So almost every other Jordanian do smoke cigarette or what we call the argila. And this is becoming common among the teens and unfortunately among the college students too. When it comes to lung cancer, you're seeing close to 70% of the patients with lung cancer present with the stage 4 disease, which is totally incurable, and the cost of the treatment is extremely high. So to do that, we just recently launched a study to screen doing the low-dose CT scans for those patients. The goal is to screen 1,000 patients to see the feasibility, knowing that when you do a low-dose CT scan, lots of those patients being smokers would have a pathology that you end up doing lots of procedures. So the feasibility and the cost is an issue. We already enrolled 170 patients in this study, as I was mentioned earlier today. We have not diagnosed a single lung cancer, but we managed to diagnose 2 renal cell carcinomas actually, but not cancer. So hopefully with the study, the feasibility, my gut feeling is not going to be feasible because lots of those patients would have abnormalities in the biopsies in society where everybody smokes. So that can be a problem, but we will have to wait until we see the data.
I just want to tell you really from a layman's perspective, I mean, what we have tried to do, we have a strong smoking cessation clinic at the King Hussain Cancer Center, and it has proven effective, but unfortunately, it's the psyche that is still not there. And we are fighting the decision makers because we are not being able to, even if laws are passed, they're not implemented. There is a very strong law that has been passed in the Jordanian parliament about not smoking in public places, which is the case in Europe, in Lebanon even, where they smoke a lot. But in Jordan, it's not enforced. It's the lawmakers themselves who break it. So unfortunately, it's actually a tragedy. And I have to say that I'm full of shame about that because what we have been able to do is a drop in the ocean, and people are still convinced that it happened to this person, it's not happening to me. They still think that, and we have tried, and we will continue to try. I mean, there is no point saying no, and I'm sure ultimately we will, especially as cancer numbers start, as cancer statistics start showing. But until now, we have not been able to really convince the psyche and to change the psyche of the Jordanian. It's crazy. We are #1 country for smoking.
No, well, we're certainly, we work very hard in this country. We're still at 12, 13%, and that's with so much effort. So it is hard, and there are some who will be intractable, but it sounds like you've got some cultural issues that, certainly you need to deal with. But I will say there's one bright spot here, and I would disagree with you that metastatic cancer in smokers is incurable. I just left our clinic where Scott Gettinger, he can show us 12, 13-year survivors on immunotherapy. So I would urge you to use the population then to do the more novel immunotherapy trials, especially if you're under-resourced. That would be a great opportunity to look at PD-1 and PD-L1 inhibitors and combinations. And I know you're meeting with some of our clinical trials people who here today. We'd love to talk to you about, some ideas we have, because that, we don't want people to smoke, but if they've already smoked and we can't do anything about it, I think the therapies will help some. Small percentage, but it's getting bigger.
I guess so. Immunotherapy is changing the history of the cancer care. Obviously, when you use it in advanced stage diseases, obviously we have to wait and see. And probably the data is very impressive when it comes to lung cancer and immunotherapy. I totally agree.
Yeah, I actually have one of those patients 10 years out of metastatic lung cancer, and she developed CML, chronic myeloid leukemia. And I actually treated her, and she has the CML is gone now, PCR able negative for years. So she's technically probably cured out of 2 incurable cancers. It's just amazing era. But how to get these medications, I guess, to the rest of the world, I think is the biggest challenge. Dr. Mehra?
I really enjoyed the 3 presentations. As a breast cancer surgeon, I really enjoyed the talk about the halving of the rates of late stage disease. Do you think that's mostly due to awareness or screening? And as you know, in Jordan, the average age of breast cancer is probably in the mid-40s, while in the United States, it's in the 60s. Yep. So do you think it's mostly from the screening aspect, or is it from public awareness opportunity?
Actually, we did 2 studies 10 years apart for a CAP study about the attitude of Jordanian women towards screening. And there are several factors. Taboo is one of them. Access to care is another one. Affordability is a third. And the most common answer we get, I don't want to know what I'm having. So this is another one. What we worked at the Jordan Breast Cancer Program, we started with the awareness to break the stigma. Then we supplied all Jordanian cities and even towns with mammographies. Now it's covered. Those cities where we don't have mammography, we have our own mobile mammographies cruising Jordan to do mammography for underprivileged women. The third, we trained tens of Jordanian female technicians and radiologists to do mammography. When I started doing mammography more than 20 years ago, we were only 2 radiologists doing mammography. Nowadays at King Hussain Cancer Center, we have 7 full-time female radiologists trained and certified to do breast imaging, from mammography to breast MRI to MRI guided biopsy, etc. So we are changing culture gradually, but I think we need time.
Thank you.
The issue is not only doing a mammogram. The problem is the outside the city of Amman, for example, you have to go beyond what's mammogram, second locally, ultrasound, the MRIs and biopsies. And that's was an issue initially. But now we trained lots of those. So in each facility, you have now a place where you can have a biopsy. We have also an accessory for advanced pathology to reach out for those patients. Now, when it comes to the treatment end, I must say that the treatment that has been available for each and everything that you think about breast cancer is available for those patients. So it's never an issue about treatment. It's just probably for patient to go forward to do their mammography and to follow up on those. It's picking up.
We have used every method possible. There are nationwide campaigns, and they have been very effective in encouraging women to have their mammogram and to be very aware of themselves. And one would be surprised, actually, that very often we found that women in the countryside were actually more responsive than in the city. So everything together hopefully will make a dent. But we've moved a lot. Like I said, we literally flipped the statistics. 70% of our women were coming at the late stages, and now it's only 35%, which is great. Not enough, but it's great. Yeah.
Another example is the cancer genetics. We face no difficulties convincing the younger females to test for a BRCA. and to do also cascade testings. The uptake for cascade testing is beyond the 40% for family members to come forward, do the testing for a BRCA. And not only that, also to undergo prophylactic mastectomies and oophorectomies if tested by hospital. So we have data already on 6,000 patients. So we thought initially that might be a problem given the culture, but actually it's not an issue at all. So uptake rate for BRCA testing is extremely high. No, actually.
Yeah, we have one last question. Yes.
You have a refugee population and the Jordanian original population.
So the question is about the National Cancer Registry. We have any data on Jordanians and we have data on refugees and in Jordan. The answer is yes. So what the National Cancer Registry report on both the Jordanian and non-Jordanians, there is the specific sections for non-Jordanians and refugees.
Do they show difference?
Difference, yes, there's a big difference in the statistics, the access for care, and unfortunately the outcome also.
What could be the reason for the difference?
The difference is the exposure, number one, for the difference in rates, for the outcome, obviously, lots of those refugees, they don't have the good access for sophisticated technologies, the surgeries, and even treatment.
Yeah, I'm actually very impressed with the program you have made. But I'd like to remind you, don't forget your tradition. That is actually may play important role in the future treatment of any diseases.
We do. We will not. Yeah, this is a tradition that's been gone in the country, and it's probably the Arab board that to extend the hands for needed people.
Well, thank you so much again for these great presentations. We have a couple of tokens of appreciations for you coming all the way to tell us about your success story that will be presented by Dr. Roy Herbst, the head of medical oncology, and Dr. Stephanie Helene, the head of hematology. So we'll start with Her Royal Highness Princess Ghida. Thank you so much again for coming to Yale. It's a pleasure.
No.